Right? Okay, good morning, everybody. You all know I do the weather report. So let's say good morning. Good morning. So today is a cold, crispy, windy morning, and we are all getting ready for the snow. But we all know that the snow is going to go away, and then again we're going to have a beautiful time. So thank you for attending this very first seminar for this season, this spring season, and also all the members on Zoom. Welcome here. If you don't know who I am, I'm Ranu Chang. I'm the founding executive director of the Institute for Integrative and Innovative Research. I'm thinking we're going to stop saying the whole name and just keep saying IQDAR, and that's our brand, So before I, introduce you to this speaker, which we are all very excited about, I thought I would take a little, just a few minutes to tell you, if you don't know and you're new and you're on Zoom and you're new, what IQDAR is, So I probably have already checked it out. We say that we are going to pioneer solutions to wicked problems. And how are we going to do that? Through a convergence research approach, bringing together academic, industry, nonprofit, all of those people together to be able to find solutions that are going to give societal impact. And of course, what is our bold vision? That we are going to be the premier convergent research leaders in that, and that we will be recognized for being able to do transformative solutions that can be moved to be at scale. And there are some 4 words that we try to say, hey, keep those in mind when you're thinking about IQDAR. Of course, integrative. And I think, innovative research, is there anything like non-innovative research? No, there's all innovative research. But and convergence obviously is very big for us. But economic development, which maybe that's something that people don't think about, but that is something we're thinking for every single item that we're talking about. And then moving things to be at scale and for societal impact. So today's focus is food is medicine. How many of you noticed that just, I think last week, if you were doing your LinkedIn post, you saw that a $10 million fund was announced. And this is from the Rockefeller Foundation and the Brothers Vision. And they announced a food is medicine impact. And what for? To improve health outcomes for millions of Americans living with chronic and diet-related conditions. And so what it says is that this new fund will promote the adoption of effective, high-quality food is medicine programs nationwide, with initial investments focused on building state-level leadership and programming. And some of you probably already know that Brothers Vision is led by Brothers World Funding. You all know we are also supported by the whole gift agreement with the Charitable Support Foundation. So this is really, at home that, and so this whole mission is very much, locally there. So it's very fantastic that it is also national and national impact. So it's a powerful intervention. And why is it, of interest to us? You might say, why are we starting this medicine talk here? Because some of you also may have noticed that we have said we will work in grand challenge. And what is the grand challenge that we are saying? Take integrative health. It is not just health, but it is also thinking about all the societal things that go around it, all the, not just physiology, all the economics, all of that put together. But in order to get integrative health, which is basically well health of the people, you need to be able to combine what we have said, the food tech sector and the health tech sector. Both are regulated industries, so think about devices and data and all that need to be the cyber aspect of it, the logistics aspect of it must be there in common. So as we are building out the whole institute, you might see a lot more things happening in the health platform, but we have been continuously in the back end doing things as we move forward for the food tech background. And let me mention to you 2 projects that are here right now currently happening. One is Dr. Meredith Atkins' project. She's an assistant research professor at IQDAR. And what she's looking at is food systems and community health research put together. And she's the principal investigator of an NSF convergence grant, and through which way they're building what they call Cultivate IQ. And what is Cultivate IQ? It's actually an AI data insights software platform. And what is that doing? It will help focus food distributors and retailers to forecast pricing and demand for nutritious fruits and vegetables. So if you pay attention to the abstract, you can start to see how it is connected. And the goal is to increase the amount of local produce available. This program has actually both a phase 1 and phase 2, and it links multiple states together. So this program has really grown well. It brings in AI, ML, there's industry partners. We are really looking forward to creating a spin-out company. Let's see what happens. So there is another project that is a very interesting project that's going on here, and that's led by our senior scientist, Prashant Ravishankar. And he's leading a research in sustainable vertical farming for nutraceutical applications. And this project has come about through the Arkansas Research Alliance, the ARA funding for industry and academics. So this is to have an innovative approach to significantly reduce environmental impact, enhance product quality, and ensure that the supply chain has integrity. And so what are they looking at it in the bigger aim? The bigger aim is to investigate the feasibility and efficacy of vertical farming for cultivating high-value urban and botanical plants suitable for delivery dietary supplementation. And the beauty is that in this building, we can do that, but we can also talk about getting those biomarkers or whatever out of those products, actually test them and look at what is the sequencing behind it. In this building, we can do all of that. And then if you decide that, hey, we want to see that becomes a product and we want to see how does it impact people, we can actually think about the food being cooked or the nutraceutical product being there, and we can run the clinical trials. All of that can happen. And with the people who are here, with our industry partners. So this brings me to our current, speaker for today. So Dr. Kelseanna Hollis-Hansen is from Tufts University. Some of you may know that we had Dr. David Kaplan come here before. We have also visited Tufts, but she brings to us a very interesting aspect to start off this year. So Dr. Hollis-Hansen's work focuses on implementing effective multi-component interventions for patients and community members living with chronic diet-sensitive conditions and food insecurity. So something that is very much of interest to us. You see the financial platform, you see us trying to see how we are getting things out of vertical farming and how do we grow this whole ecosystem. So partly we want to learn from her, see how we're going to grow that entire part. So for over 15 years, she has worked in developing and evaluating interventions that improve the food retail environment, grocery stores, food factories, and pairing direct access to nutritious food, medically tailored meals, medically tailored groceries, meal kits, SNAP, WIC enrollment, all of that with behavioral strategies that support healthy eating and household resilience. And we have said this over and over again. We are interested in deployment. You don't get deployment. You can make all the tech you want, all the platforms you want. You really need the community to buy into that this is good for them. And only then you can actually get solutions deployed. And so she's really looking at that entire spectrum at that end. Kelseanna is currently a research assistant at Tufts University Food Medicine Institute. She's the director of the entire New England Regional Collaborative for Food is Medicine. In addition to her faculty position, she serves as a program advisor and consultant on behalf of the Center for Nutrition and Health Impact, and she co-directs the healthy eating research, early stage investigator work. She was previously assistant professor at UT Southwestern Medical Center in Dallas, a T32 paid NIH for the support, postdoctoral fellowship, or USDA probably. I don't know. She will tell us about that at UT Austin. And she's also spent time as a grad student in Buffalo, so she understands snow. So I'm delighted to have you here, and I also want to congratulate you, Kelseanna, for your first R01 from NIH. So welcome.
I actually wasn't going to announce that because I haven't got my notice of award.
Oh,
I thought about yesterday, but I am such a deep one, so I'm very excited. Thank you so much for having me here, and I was just really seeing everything that QDAR is doing was very exciting. Meredith is wonderful and does great work, so thank you. I'm not going to introduce myself because that has already been done. Just setting the foundation here, thinking about chronic diseases in America. So about 6 in 10 US adults have a chronic disease, and about 4 in 10 have 2 or more. the leading causes of death and disability and the leading drivers of the nation's $3.5 trillion in annual healthcare costs are owed to these 7 conditions here: heart disease, cancer, chronic lung disease, stroke, Alzheimer's, diabetes, chronic kidney disease. And what we notice with all of these is that there is an element and component of diet influencing these outcomes. And I think many of us know, but this is largely owed to our food environment in the United States. It's not a failure of people choosing the wrong foods to eat necessarily, but the fact that we have these highly ultra-processed foods that are very readily accessible and affordable. So just a little background, little personal background here. My parents were teenagers when I was born, and we had limited resources. I sometimes was living in public housing. My dad still lives in public housing. My mom was able to really change our economic experience by improving in her career, but with that came extensive work hours. And so most of my childhood food came from corner stores. So this is like a day of food for me as a child. I would have a package or 2 of mini muffins on the way to school because my mom didn't have time to make breakfast. Have a box of macaroni and cheese or the school lunch. And then for dinner, I would have some of these Pizza Hut corner store pizzas. And what you can see here, like when you look at the daily value, total fat, sodium, and sugar, extremely high. And these are based on adult daily value. And I was a child eating these foods. So as you can imagine, not the healthiest, but not a failure or challenge of my parents. It was more the constraints of our life. From there, I went on to college and I was exposed to so many new people and concepts. I participated in student rescue, where I would drive a really large van to pick up leftover food from Panera's and other restaurants and bring it to shelters and pantries. And at this age, it was the first time that I started thinking about the concept of a food system and really, what if? Like, what if my city provided tax credits and other incentives to provide healthier food options in those corner stores? What if instead of just mini muffins, there was fresh cut fruit and granola and yogurt parfaits, and instead of Pizza Hut pizza that was homemade with whole wheat and fresh fruits and vegetables from our local farmers? I know this figure is really intense, but when we're thinking about a food system, and I want to clarify, I didn't create this. This is from Dr. Zhang and a team of international food policy researchers. But I really like it because it shows us this systems thinking model with feedback loops on how interconnected our food system really is. So we have our resource inputs like seed and water and sunlight. We have our farmers and their human labor, which generates food, which travels to our food wholesalers and aggregators, which then also goes on to our food companies and eventually our grocery stores. This influences and is influenced by our government and policies, like food production and retail regulations, our taxes and subsidies, and all of these things are reciprocally influenced by our social domains. As consumers, we use our buying power to shape our food system, and in turn, this impacts our health system. The availability and the quality of our food ecosystem influences our food security and diet quality, which directly impacts our health outcomes. And well-being, which again goes back to influence everything else through the waste that we generate when we're producing these foods, through our buying power. For example, if we're unable to work due to being ill from these chronic conditions, we have less money for buying food from the market. And again, if we're producing too much waste, we negatively impact our land, water, and air, which again impacts the quality of the food in our food system. So just stressing the interconnectedness here. And as a specific example, we now know that excess air pollution like carbon dioxide has been shown to actually reduce the amount of zinc, calcium, iron, and potassium in our crops. So this then perpetuates an unhealthy system and cycle. And we need to think about these things as interconnected, intimately interconnected, because they are. So I want to ask briefly here, what nutrient or nutrients impact blood pressure? You could just yell it out.
Salt.
Yeah, sodium. Right. But also, sorry about that. Wasn't clicking. It's also potassium. So most commonly, people are focused on sodium and sodium reduction. And while it's vitally important to reduce sodium intake to improve blood pressure, Many people forget it's also important to increase and add potassium, and that doing so reduces blood pressure as well. So if our greenhouse gases from our waste are reducing micronutrients in our food sources, and we're already not eating enough of the foods that offer potassium, and we're eating too many of the foods that are high in sodium, we're increasing our likelihood of developing high blood pressure, which is a significant risk factor for several of our leading causes of death in the US. And some of you are probably really familiar with this type of figure. This is usually put out by the CDC, but this one in particular comes from Dr. Ahmed and co-authors and was published in JAMA. But it shows our top 10 causes of death from 2019 to 2023 are heart disease, cancer. I'm not going to list them all because I kind of already did on the first slide. But what I want to point out is that 4 of these diseases, heart disease, stroke, Alzheimer's, and kidney disease, have a direct link to high blood pressure, and 7 have a direct link to diet and the food system generally. All of them have an indirect link. So for example, poor diet quality and diet-related diseases are linked to higher rates of mental health challenges like depression, which increases our risk for suicide. And our diet-related diseases were also associated with higher rates of hospitalizations and greater likelihood of death from COVID-19 and other infectious diseases. And this increased diet-related disease is in part caused by our unhealthy food environment. As a play on the USDA My Plate, which is no longer in use currently, unfortunately. But this was created when My Plate was still in play, and it was the Standard American Diet, or the SAD plate. Using data from national nutrition surveys, researchers found that about 58% of our diet comes from ultra-processed foods like donuts, chips, and sugar-sweetened beverages, with only about a third coming from minimally processed foods, which are vital to our health, like fresh fruits and vegetables and produce. The Eat Lancet plate is similar to USDA's My Plate, with some small tweaks based on decades of nutrition epidemiology research, and it takes into account things like sustainability and food equity, and they recommend that half of the plate be made up of fruits and vegetables, and to consume slightly more vegetables than fruits, but to be sure to get a wide variety of bowls to ensure we get enough of the different micronutrients we need in addition to those macronutrients like carbs, fat, and protein. And so I really like this Eat Lancet plate, although I know nutrition epidemiology is always hotly debated. But how do we get from that sad plate that we currently have to a happy plate? And I propose that food as medicine programs can help us do this. So although the concept of using food to prevent and treat diet-related diseases is not new, there is renewed attention. As Dr. Jing pointed out, there was just $10 million in funding. There's been significant millions and millions of dollars invested by the federal government, as well as these nonprofit organizations. And if you're less familiar with this concept, this food as medicine pyramid was created by researchers at Tufts University before I was there, so I don't want to take credit for this great pyramid. But there are 5 general groups or types of programs that we recommend to make improvements in our diet-related disease outcomes. We have our population level policies. So I talked about these a little bit already, like sodium reduction policies that may require companies to reduce the amount of sodium in foods, taxes for sugar-sweetened beverages. Above that, we have our nutrition security programs like SNAP and WIC, which provide funding from the federal government to purchase healthier food options. Above that, we have, and these 3 at the top are commonly what are really thought of as food as medicine interventions, but produce prescriptions, which is like receiving a box of produce delivered to your home or picked up from a central location, receiving a gift card to purchase fruits and vegetables. Above that, medically tailored groceries, which are similar to the produce prescriptions, but add things like whole grains and lean proteins and dairy. And then at the very top, we have medically tailored meals, which are prepared frozen meals that are created to treat different chronic diseases, typically those that may limit one's ability to prepare food, like chronic heart failure and severe type 2 diabetes. And we think that the science-based priority for healthy eating would follow the food as medicine interventions would be tailored to something like this. So foods like fruits, nuts, fish, vegetables, plant oils, whole grains, beans, and yogurt would have benefit and be protective for health. Foods like cheese, poultry, milk, butter, eggs would be in the eat in moderation category. And then at the bottom, we would want to minimize processed grains, starches, sugars, processed meats, high sodium, foods, and industrial trans fat. And so as you can see along this scale, we have our minimally processed foods at the top to our ultra processed foods at the bottom. Sorry, I am allergic to this region. That's part of the reason especially at this time of year, I have I don't know, it makes my throat really scratchy. So I'm sorry about that. Thanks for being patient while I take my sips of water. But now, how have we operationalized these programs in my research? And I'm going to share this example from the FRESH study, which I think there's about 100 FRESH studies in the literature, but ours is Fundamental Resources Empowering Sustainable Health. This was a randomized, repeated measures between subjects study of 210 people funded by the American Heart Association. We recruited people with hypertension, diabetes, dyslipidemias from Parkland Health, a local safety net center. And I'm going to go forward and then go back here for a second just to give you the landscape of the setting for how all of this took place and what we did here. So this is the Redbird Mall. It was purchased by a wealthy businessman in Dallas and was completely renovated with years of input from the community. In this location, we have our major medical providers, UT Southwestern Medical Center, where I formerly worked, and then Parkland Health, which is the local safety net hospital system that serves between 1 million to 2 million patients a year. You have typical retail shops in here, like clothing stores and food retailers. You have low-cost apartments, Dallas Workforce Solutions, and a number of great community resources. And then in addition, during this study, we created a satellite pop-up pantry for our food pantry partner, Crossroads Community Services, who Dr. Tammy Leonard here, who was an MPI on this project, and another one of our co-investigators, Dr. Sandy Pruitt, has worked with for over 10 years, and they graciously connected me to Crossroads when I was coming to Southwestern. And we still work together. That's actually who the RO1 is with. We'll be extending some of this work I'm presenting today. But Crossroads serves about 160 pantries in the North Texas region. They redistribute food, and then they also serve about 12,000 to 20,000 people in their main market site. They provide families as their standard of care with $250 worth of groceries per month for a family of 4 on average. And in this study, what we did was had a control group that received those Crossroads usual services, which are already pretty great. And then in our intervention groups, they received medically tailored groceries for those 3 conditions. So we tailored to the DASH diet because it was evidence-based and shown to be effective for all 3 conditions. And then in group 3, they received the medically tailored groceries and food resource coaching, which was developed by Dr. Leonard and Crossroads to help support community members with things like goal setting, managing financial crises, getting enrolled in employment and food assistance programs, meal planning, and budgeting. So how did we actually medically tailor these groceries from the pantry? Crossroads allows their community members to basically purchase, it's almost like purchasing food, but using points. And these points are based on an algorithm that follows USDA dietary recommendations based on the age, sex, and activity level of each person in the household. And these were the former dietary recommendations because this took place last year. But the quantity of medically tailored grocery, so actually I'm going to back up for a second. So this is a sample screen from the Salesforce inventory that's been created to be like an online grocery store. And community members come into Crossroads, they sit down with a team member, and they make food selections using this platform. They pull the food item they want over, and then it calculates their points for them. We medically tailor these groceries by pre-populating their cart with foods that align with the DASH diet. So Dr. Albin, who is also an MPI on this project, and a registered dietitian named Willette Seiler, and I all kind of tailored the inventory at the pantry to the DASH diet, and all foods that were ranked a 4 or a 5, which are most optimal, were pre-populated in the cart. Crossroads is a client choice pantry. So they are able to remove or swap any items. But we actually just finished I'm not presenting out the data from this, but we just finished our analysis, and we did find our medically tailored grocery groups did select significantly more of the medically tailored groceries, suggesting that they did accept the intervention and adhere to it. Our usual services shoppers, our control group, had an empty cart and were self-directing their food selection. So the medically tailored groceries are always available to them because it would be inequitable for them not to be, but they're not pre-populated in the cart. So what did we find in this study? Our main program or primary outcomes were focused on program feasibility. Can we recruit and retain from this population? And about 62% of those eligible did elect to enroll, which if you do food as medicine interventions is actually a really high number of people. It's usually about like 20 to 30%. So we were double that. And of the 210 people that enrolled, 81% completed the study. So also meeting that kind of gold standard of 80% or above on retention. So we were really excited about that. Who were our participants? Predominantly, they were women, about 83% female. They had about 3 people in a household on average. Most were Hispanic or Latino or Latina, or African American or Black. And then we looked at the health conditions because they only had to have at least one, but about a third had one of those 3 conditions. A third had 2 of them, and a third had all 3. So really significant burden of chronic disease, and also like multiple chronic diseases. What did we find? So 623 appointments were completed at Crossroads. We distributed over 37,000 pounds of food, which was equal to about 30,000 meals. At the end of the study, we were able to pull data from the EHR. We couldn't take primary data collection because it's too expensive. And even though it was 210 people, this was technically a pilot study. So we didn't have money to like take these measures, unfortunately, although we will in the R01, so that's exciting. But for patients who had come into Parkland and had gotten A1C recording or blood pressure recording within 30 days of baseline and within 30 days of follow-up, we were able to look at their data. There was only about 40 of them for A1C, so we didn't do comparisons by group on that because it was just too small of an N. But of those 40 people, about 50% of them had reduced their A1C. For blood pressure, I am going to show you the group comparison because there was 166 people who had blood pressure available in the EHR, and 56% of those had reduced their blood pressure by the end of the study. Our secondary measures were perceived diet quality, perceived health quality, and nutrition security. So we found that participants had large and significant improvements in perceived diet quality over time, with a trend toward greater improvements in the medically tailored grocery group, although it was not statistically significant, but still promising and trending in the right direction. In terms of perceived health, similar trends, so large and significant improvements in perceived health, with a trend towards greatest improvement in the medically tailored grocery plus coach group. For blood pressure, there was a statistically significant decrease in systolic blood pressure and diastolic blood pressure, but just presenting one for time's sake. The interaction was not statistically significant. However, the medically tailored grocery and coach participants were trending towards greater improvements than the control. There is potential for like a regression to the mean effect here. We'll look at that in further study, but we still feel like these are promising results and supportive of continuing this work. For measures of program satisfaction, at the end of the program, participants indicated they agree or strongly agree that the food provided was helpful, good quality, and that enough food was provided. Most participants also felt like they knew how to prepare the food that they received as part of the study. And we did provide recipes to each of the groups as well. The medically tailored grocery plus coach group specifically got the recipes introduced to them and were recommended to use them to prepare the foods they got from the pantry. So it was great to know that most people felt, I'm getting maybe newer types of food, but I do know how to prepare them. We asked how likely is it that you would recommend this program to a family member, friend, or coworker, and over 90% said at 8 or above, and 77% said 10, very likely. So people really enjoyed this. And then we did do qualitative interviews for 60 of the participants, both pre and post intervention, still working through analyzing some of these. But here's a quote I love from one of our participants when they were asked, like, what did this program do for you? So she said, basically just eating healthier. Those recipes really just gave me an opportunity to eat more cleaner and to know that it's actually healthy for me, that it has benefits. You know, as I said before, finding out I was a diabetic, I was all in my head, not trying to accept that I was and still wanting to eat the same way. But you know, when you guys are giving me healthy options and the kind of food that you had and the recipes that you were getting out, it just kind of helped me realize you can eat more healthy and more cleaner. And it's okay. It's more of a lifestyle change. And that's really the goal and focus of the programs that we're creating here. And then on the left, this is a purse and a tortilla warmer that one of the participants created for her food resource coach. We also had this like gratitude board during Thanksgiving, and a ton of people wrote like how grateful they were for us and the people that were providing them food. And it was, you know, just really beautiful to see how much this impacted our community. So our long-term goals, Crossroads opened their permanent satellite site at Redbird this past summer. We're continuing to evaluate that. You know, it's not a randomized control trial, but we'll be reviewing the actual implementation and linking that with EHR data as patients are now referred from both Parkland and UT Southwestern. Going back to that whole food system focus, what I also see as the promise of food as medicine is the ability to support our local economy and our local growers and producers. So myself and Dr. Alvin and the auxiliary services at UT Southwestern worked very hard to get local farmers contracts, vendor contracts with us. So now we're able to purchase food directly from local farmers for providing some of those fruits and vegetables, which is a way to stimulate their income and our local economy. So our main goal is to build a supportive and sustainable program for patients that may not otherwise have access to healthy foods, and to set that foundation for healthy habits for life. And we'll continue to apply for longer and larger projects. We'd love to do multi-site trials. So I've been telling everyone, if you want to do a multi-site trial and have an Arkansas site, I would love to collaborate. So please connect. I'm starting similar projects to this in New England as well. I just had one recently funded in collaboration with the University of Massachusetts and a food pantry called The Open Door, which is in Gloucester, Massachusetts. Super excited about this because we're actually working with local fishers and the Gloucester Fishermen's Wives Association to purchase seafood from those local fishers and to support our local fishing economy. And the women from the Fishermen's Wives Association are going to do demonstrations and teach the community like how to actually prepare the food. And then we're also purchasing local produce from the New Entry Farmers program to support the local farming economy. How am I doing on time?
You have about 40 minutes.
Oh, wow. All right, good. So I wasn't sure if I wanted to present on this, but since GLP-1s are such a hot topic right now, and I did a pilot study on food as medicine and GLP-1s, I do want to share this with you. So I think everyone's familiar. GLP-1s are showing significant improvement in type 2 diabetes outcomes and weight. However, they do have really high costs. So they're about $600 billion a year. There's significant side effects like gastrointestinal side effects, like gastroparesis, which is like slow gastric emptying. There's insulin bone loss. And unfortunately, once people go off the drug, most lost weight is regained within 6 to 12 months. So this figure here, if you look, is from some of the step trials. So you see like significant decrease in weight, then people stop the drug and significant weight regain, particularly in the 3 to 4 months after stopping the GLP-1. In a recent study of over 195,000 people, GLP-1 discontinuation was about 26%, 31%, and 37% at 3, 6, and 12 months respectively. So pretty high discontinuation rates. Patients with obesity had a higher prevalence of discontinuation at 12 months than those with type 2 diabetes. And each 1 percentage point increase in out-of-pocket costs for a 30-day supply of GLP-1s was associated with 2% increased odds of discontinuation. So really expensive. People stop them for all sorts of reasons. And we don't quite yet know what this like cycling of GLP-1s is going to do. This is a study from researchers in England. And it just came out recently. It was a systematic review looking at nutrition strategies for people on GLP-1s. And they found that across studies, energy intake decreased from 24% to 39%, but lean tissue loss, so like our healthy lean tissue loss, accounted for up to 40% of that total weight loss. Only 3 studies that they reviewed here involve nutrition professionals and systematic assessment of protein or micronutrient intake. One observational study found widespread nutrient inadequacies and limited access to dietetic support. So while GLP-1s are having these amazing outcomes, they're not necessarily improving every part of nutrition-related outcomes. And so this was actually created by our director at the Food as Medicine Institute, Dr. Dariush Mozaffarian. He and a number of other physicians published this joint statement on the importance of coupling GLP-1s with nutrition and lifestyle interventions. They posit that doing so would help manage some of those gastrointestinal side effects, help people navigate dietary preferences and intakes, prevent and mitigate some of those nutrient deficiencies we're seeing in people with GLP-1s, help to preserve some of that muscle and bone loss. It would maximize the weight reduction efficiency, promote other supportive lifestyle interventions like physical activity, and that it would have a more patient-centered approach. So GLP-1 drugs are approved for obesity as an adjunct to nutrition and lifestyle. So in this pilot study, I would have loved to implement food as medicine throughout the entirety of people taking the drug, but I only had a few months to intervene because it was only like a $50,000 pilot. Because few people are looking at like that weight management and what happens when people stop drugs, we actually focused our efforts there. So we did a small pilot study where we randomized people to receive usual care after they stop GLP-1s, which is really dependent on the provider. Most of the time it's nothing. Maybe like follow-up conversations or like brief counseling with their provider, but it's very consistent. So we had usual care as our control group. One of our groups received medically tailored meals, and one of our groups received the app Noom, which is a behavioral app that supports healthier eating and healthy lifestyle change. So our focus was, again, like pilot feasibility was our first aim. Was it acceptable? Did people adhere? Were they satisfied? And then we also wanted to see like what happens with weight regain. Can food as medicine or Noom help people regain less weight than people who receive usual care? And another one of our reasons for this was because these interventions are so much more affordable than GLP-1s, right? The average cost of a GLP-1 is, and it has gone down a little bit, but it's like $400 to $600 a month, which is completely unaffordable for most people and most insurance companies, and honestly for our federal government, right? So Noom is about $17 to $70 a month, depending on how many months you buy, and medically tailored meals are on average about $372 a month, which is still expensive, but significantly cheaper than a GLP-1. This was, again, I really like these kind of studies, you can't tell, but it was a randomized repeated measures between subjects design. Again, I probably would have liked to do like Noom and food as medicine together if given the opportunity, but we were just constrained by budget. We'll do that in the future. They received the interventions for 4 months. They got a Bluetooth scale to weigh themselves at home that we mailed to their home, and or asked to use it at least once a month and received like reminders to do so. And they had to enroll in this study, they had to have at least 10% body weight loss from taking the GLP-1, and they had to have stopped taking it within the last 30 days. And they couldn't have a medical condition or dietary restriction that would stop them from being able to eat the medically tailored meals. And just a little more detail about Noom. It uses principles of psychology and behavioral economics to really encourage healthier eating. They, as you can see from like the right-hand side of the screen, you get like coins and incentives and encouragement for tracking your food and engaging in their different lessons. Noom actually has a really strong evidence base around it, both like from their internal research team as well as external evaluators. What the research shows is that using Noom for 15 minutes a day can lead to significant weight loss as well as weight maintenance up to 2 years. So pretty sustainable intervention if people continue to use it. So that's what we used as our kind of prescription for Noom, was the 15 minutes a day. And then medically tailored meals were purchased from a vendor that provides dietitian developed meals for weight wellness and meet nutrition standards that are set forth by the Food as Medicine Coalition. Someone asked me this last night, like, what are the nutrition standards for medically tailored meals? They're inconsistent, I will be honest with you, but they're supposed to meet the dietary requirements for whatever disease condition they're focused on. And kind of the best guidance we have so far is the Food as Medicine Coalition standards. In this study, participants received 10 medically tailored meals per week delivered to their home for 4 months. And that's based on prior literature suggesting that that's the number of meals needed to both maintain or lose weight and to reduce HbA1c. For time's sake, I'm just presenting our results on percent body weight change because they're the most exciting, I think. But what you see here is starting at baseline to end of month 4. The blue line, which is the one on the top, is usual care. The green line, which is in the middle, is the Noom intervention, and the orange line is our medically tailored meal intervention. So for all participants, they have that weight regain once they stop the drug within 30 days of stopping the drug. But we really start to see divergence here around month 3, where our usual care participants are increasing significantly in their body weight as compared to our Noom and medically tailored meal participants. And by month 4, it actually looks like our Noom group might be doing a little bit better. But we find this all to be really exciting. And in future trials, would ideally like to start those food as medicine and behavioral strategies and the GLP-1 during treatment. We'd like to obviously have larger samples and longer intervention. It was only 39 people. So definitely want to stress that these are pilot results and need to be replicated in larger studies. And we want to see like which intervention has highest satisfaction and adherence, as well as preliminary efficacy and cost effectiveness. But I find that to be exciting and a possible avenue for future intervention. Okay, I was also asked to talk about food as medicine policy. So I'm switching gears a little bit here. Want to give full and total credit to Dr. Katie Garfield, who's the director of whole person care at Harvard Chilpy, the Center for Health Law and Policy Innovation. Tufts FIMI collaborates very closely with Chilpy. And you know, they're really the leading policy experts on food as medicine. So for those who may be less familiar, there's 3 different kind of policy levers that we have to pull regarding food as medicine. So we can have law enacted by the legislature. We can have regulation, which would be declared by agencies to implement the law. And then we can have guidance, which are the supplemental materials from an agency to help interpret and clarify law. There's some exceptions to this. We also have executive orders. I think we have all been hearing a lot about executive orders in this presidency, so we're probably more familiar with them than usual. But they can direct agencies to reverse guidance. They can also establish new policy mandates. And then there's reconciliation, which is a special process for spending, revenues, debt limit legislation. And these are, again, just like the different ways we can think about leveraging federal policy, and in some ways state policy, to implement and support these food as medicine interventions on a wider scale. Because most of what I presented to you so far are like these demonstration projects that are a little bit smaller scale, but there are a lot of opportunities for wide-scale implementation of food as medicine. So the legislative opportunities we have right now, Medicare has a medically tailored home delivered meal program pilot act. There's a medical nutrition therapy act, which allows reimbursement for MNT or like dietary counseling. The VA has the Veterans Nutrition and Wellness Act. And then there are proposed budget and appropriation opportunities that we could support, like $2 million to support Health and Human Services Food as Medicine initiatives, and $7 million to support the Indian Health Service to do a produce prescription demonstration. And these items reflect shared recommendations for fiscal year 2026 from the AHA, Chilpy, that Food as Medicine Coalition, us at the Food as Medicine Institute, and the National Produce Prescription Collaborative. So kind of these major organizations of food as medicine, these are the priorities we've recommended. There's also another element to this. If you are working in the medical system or healthcare setting, you might be more familiar. There are, and this is not my area of expertise, so I don't want to misspeak here. But there are what are called patient inducement rules. So there's an anti-kickback statute, and there's a civil monetary penalties law that prohibit offering anything of value or a value to induce Medicare or Medicaid patients to use federal healthcare services. So basically, there's this weird gray area around providing patients with food because potentially it could be in violation of this anti-kickback statute. So some health systems are, a little bit nervous about implementing these strategies. So what we have recommended is for IRS to change different reporting requirements and to for OIG, the Office of the Inspector General, to establish this safe harbor for implementing food as medicine programs to really encourage and facilitate this widespread implementation. So those are just some of the examples. And then this next slide. This data is from Erica Hansen. She's also at Chilpy. She published a paper in 2024 showing the Medicaid status where different states were implementing food as medicine waivers, demonstration waivers that would allow Medicaid to cover food as medicine benefits. She sent me updated data a couple weeks ago, and then I put it into this map. So currently 13 states have approved 1115 demonstration waivers. So that means that they can provide Medicaid funds for food. Those states are California, Colorado, Delaware, Hawaii, Illinois, Massachusetts, North Carolina, New Jersey, New Mexico, New York, Oregon, Pennsylvania, and Washington. And then there's 3 states that are currently awaiting approval. So that's DC, Maine, and Nevada. There's another Medicaid strategy that can be used. It's called in lieu of services. So in 12 states, they're able to provide nutrition support in lieu of other services for specific chronic conditions. 3 states have also introduced bills to advance food as Medicaid financing this session, which are Florida, Indiana, and Missouri. And then 6 states have enacted legislation to advance food as medicine Medicaid financing, which are Alaska, Colorado, Minnesota, Oklahoma, Texas, and Wisconsin. And this looks very different depending on state. They might focus on different conditions. So I was most recently in Texas, for example. The legislation we have proposed is specifically focused on pregnant postpartum women. But I want to show you this for kind of generating thoughts about maybe what can be mobilized and done within the state of Arkansas. And then the other federal funding that can be provided is by use of Medicare Advantage for specific conditions. Again, this also varies by state, but a much larger portion of the country is able to leverage some of these benefits to implement. The other promise of kind of widespread implementation of food as medicine are these digital tools. So these are kind of complements to the medically tailored meals, the medically tailored groceries, produce prescriptions. There are these new food rating systems through Yuka, Kroger, and the Open Food Facts that allow people to kind of scan a product and see whether it would be a medically tailored grocery product. There's new AI meal planning tools. We and others are partnering with Instacart to implement online groceries and nudges and recipes into their algorithm to encourage people with chronic diseases to make healthier selections in Instacart. There's opportunity for continuous glucose monitoring to be leveraged to provide direct feedback, right? So if you have a patient with prediabetes or diabetes, they can log their food. They can see how is my glucose directly responding to this food, which could be really enforcing for encouraging more consumption of those medically tailored foods. And then there's January AI has an AI photo logging and glucose prediction app, which is really cool. And then it also provides health coaching to say hey, this food really spiked your glucose today. I mean, this is not the language, it's much more user-friendly, but maybe instead of eating this granola bar, have this food instead. There's also significant investment from private payers. So we have a network of excellence on food as medicine, which includes all of these major insurance companies across the United States, as well as some of the foundations. So the Rockefeller Foundation was mentioned, and the American Heart Association. And we work together to do a number of things. Just in the next coming months, in partnership with Kaiser Permanente, we're going to be putting live a national toolkit, somewhat similar to the HHS toolkit, but expanding even further on different recommendations of really how to implement these programs in health systems across the country. And so we also do this kind of technical assistance work as well. So our priority research and clinical questions generally are, what is the impact in these key populations? Patients with diabetes, CVD, kidney disease, complex conditions, our high utilizers, high-risk pregnancy, depression, people that use GLP-1s. How do we best tailor these meals, groceries, and produce to really be aligned with the different cultural preferences people have or food preferences people have? How tailored does it need to be? Like how strict and specific? We don't necessarily know that yet, so that's a big focus. When we're providing our nutrition and culinary education strategies like culinary medicine, where community members come together in a group to meet with their physician or a registered dietitian to learn how to prepare the healthier foods in a medically tailored grocery bundle. How do we want to deliver that? Virtually, in person, hybrid? How often do they need to meet? Questions around that. How do we provide education to doctors to support the electronic health record screening? How do we best implement the clinical care pathways to get patients from screening positive for food insecurity into these programs and adhering to them? How do we, where do we source the food from? What is most efficient? And again, to like my heart's desire and focus, how do we take that local food systems approach and really invest back into our local producers? So the Food as Medicine Institute envisions a world where consumption of nutritious food is recognized as a fundamental component of health and healthcare, and where all people and communities have the knowledge, resources, and support to achieve optimal health and health equity through nourishing food. So to that end, we have these 4 major pillars. We're committed to clinical practice, education, research, and advocacy that builds a supportive, sustainable food system and advances food as medicine programs to ensure patients, especially those with limited access to healthy food, can obtain those nutritious foods and develop healthy eating habits that set the foundation for better health for life. This is the New England Regional Collaborative that was mentioned that I helped to support. We have over 19 organizations. We advise each other on local policy. Some of the states like us in Massachusetts have that 1115 waiver. Maine is about to be approved. We work together to share strategies about like how did you do this? How did you mobilize? How did you get this supported? We provide just learnings of like, I tried this recruitment strategy and it was terrible and nobody joined the study, and then I did this instead, and this is how we got more patients to enroll. We provide just different support and apply for grants together. So just sharing like some of these ways that we're really mobilizing food as medicine so that you can consider opportunities here. And then this is some of our national partners that we work with most closely to implement. And my next, as I've been saying, come work with us. We want to work with everybody. We want to implement these food as medicine strategies on a really wide scale. And I'm actually done, even though you said I have 20 minutes, but because I thought I was starting at 9. So I was trying to time for that. But I want to say thank you to our Tufts Food as Medicine Institute faculty, staff, and students, especially our director, Dr. Dariush Mozafarian, and our managing director, Cecilia Gerard. And then want to thank all of my collaborators and our team in Texas. So Crossroads Community Services, again, is the large food pantry that we work with there. All of the collaborators on that FRESH study, as well as some of my other pilot studies, are there. Our team that actually works every day with the community members and supports them is over on the right there. Special shout out to Carolyn Haskins, who's our project coordinator, and Jessica Tercios, who's a senior research associate, who really do that on the ground work to establish trust and really care and love for the patients that we're working with. And then some of the funders for the pilot study I mentioned, and a whole bunch of studies I didn't have the opportunity to chat with you about today, but I'm happy to talk about further. And I will take questions.
Yeah, we have a thank you so much. And
Wonderful, quite a comprehensive thing, and it's amazing to see the policy yet all the way those studies in. So really great. So
We do have a few questions online. We'll start online and then we can go to the room. So, Dr. Let's see here, Ali Ubichikolari from University of Arkansas Food Engineering for Health Lab asks, says, great talk. How do you see the role of food processing on developing nutritious, healthy, and safe foods, especially its impact on food security? The shopping cart shared on medically tailored groceries had overwhelmingly processed foods.
Yeah, so, well, I would argue that they're minimally processed, right? So we do definitely use canned and frozen fruits and vegetables because they've been shown to be equally as beneficial for health and are also more affordable. But we have, in terms of the other ultra processed foods, it's pretty minimal, maybe like whole grain pastas, but even then it's like whole durum wheat, so it's not too terrible. But I think that, asking about like the generation of new food products, I think that's going to be vitally important, especially as climate change continues to impact our producers and growers. So my understanding is here you're working on developing some of those foods, as you presented on in the beginning, and then Tufts is also doing some of the same in terms of things like lab-grown meat and developing like drought resistant crops and things of that nature. So I think that that's all. I think we should, I hope my main message for my talk today is like, I don't really want us to just be thinking about like prescribing medically tailored meals for everybody, right? Like I want us to be thinking about how food as medicine can touch every single element of the food system to influence and be influenced by that, to really generate these new food resources, support local economies, and then provide nutritious foods to our community members and improve their health.
Thank you. One more. I'm here online. Cynthia Moore from the Alice Walton School of Medicine and Georgetown University Health and Wellness Coaching Certificate Program. Just was interested in knowing if the Mosifarium visuals are available for use with medical students. For instance, are they embedded in reference articles?
Yes. So going back here. This under research, this figure is in one of our publications that I can send out after. And there's a version of this map, like I mentioned in a 2024 publication, but it's not yet updated. But I just created this myself and it's like a program, so I'm fine if you want to use that. Trying to think of any of the other visuals, but yeah, there's a number of publications and they're all available on our website. And as long as they're appropriately cited, they can be used for anything.
open to the audience. Yes, Margaret.
This seems like an area that's really ripe for collaboration between pharmacies and grocers. I was wondering if you could share a little bit on what you've seen with like Tufts collaborations with Kroger or Walmart or other grocers and what they're trying to do in this space.
Yeah, so I don't even know how many research programs we have at the Food as Medicine Institute. I know it's like over 40. And then myself, I have like 10 different projects going at any different time. So one of the projects we have is called CP3. It's a community pharmacy medically tailored grocery program. I think it was technically called produce prescription, but we are providing other foods. So it is actually a medically tailored grocery program. And it's in partnership with like Kroger and Walmart. And there's a third that I'm blanking on. So I apologize to that third retailer. But we are having the community pharmacies screen for food insecurity and other conditions. And then they're actually providing the food directly from that food retailer. So when they go to like pick up their medication, they're getting that interaction and then the food is being delivered to their home. But we don't have results on that yet. I know we've enrolled, I believe, like a little over 200 people. I think it is, it's places that people are already going. So I think implementing in food pantries and grocery retailers, these places that people are visiting in their day-to-day is a phenomenal strategy for actually reaching people where they are. Some of the programs also home delivered, and where I was talking about kind of some of these questions, that is an open question mark too, because some people love having food home delivered. Some people prefer to actually go and pick it out themselves or pick it up in person. So I think we'll continue to learn like what is the optimal strategy and how we can best tailor to these different preferences that people have.
Yeah, absolutely. I think one of the number one trends in retail is convenience. So if you're able to integrate that with like pickup, delivery, all of that, and
Yeah.
for the person to get it. Thank you.
Any questions? Yes.
Hey, Kelseanna, thank you for coming to Arkansas to visit us this morning. Your story about growing up in a household with economic challenges and the fact that you work with a social safety net hospital or provider, I think highlights a really important thread that we don't always talk about in food as medicine, which is the socioeconomic part, the economic aspect. Could you talk a little bit more about how that's, in some models of food as medicine kind of central, like this sort of blending of it's an economic program to give people money for groceries, but also it has its healthcare implications.
Yeah, and I think there's a lot of, so there are some voices in food as medicine that feel like this is really for treating chronic conditions and it doesn't matter like what the financial situation is. But I think food as medicine will probably have the greatest impact on communities where there are challenges around food access because they're getting that direct kind of offset of costs, right? Like in our study, it's equivalent to $250 worth of groceries a month. Then that means $250 can be spent on other household expenses. So I think that there is real promise there to support household resiliency. And I think all of that though has to be done like before the Fresh study conducted over 1,000 taste tests in the food pantry, 200 cross-sectional surveys on cultural food preferences, pilot randomized control trial with 70 people testing some of these different foods, right? So I didn't have time to like share with you all of the background and investment that we made in really understanding like what our community members did. And so I think that that's another really important component. And understanding that like economic security and food security looks very different for so many people. There are, research shows that there are significant time scarcity challenges. Like sometimes it's assumed that people with lower income are not working, but many of the times they are working, they're just working multiple lower wage jobs, which was the case for both of my parents in my early childhood and my dad to this day, right? Like he, yes, receives social security benefits, but he also works actually at a grocery store stocking shelves. He just can't work more hours than a certain amount. So really understanding these, like what are all of the different barriers and challenges and how can we address those for different patient populations.
Thank you very much. Very interesting. So if I understood correctly, that you are focusing more with adults, right? Educating them. So are you thinking to educate maybe much earlier stage with a school kid?
Yeah, so I do have, it's still adults, but I currently have a planning grant in collaboration with UT Health for pregnancies. So to reduce risk for gestational diabetes and improve like postpartum outcomes. And we know that doing so can have kind of set the trajectory for health for life, right? Like eating an unhealthy diet in pregnancy has been associated with adverse later life health outcomes. So if we're able to provide these nutritious foods during pregnancy, maybe we can help set the foundation for health. So that's one way I'm thinking about children. And then we do also have programs that are focused on like culinary medicine with parents and children. So working with the Spark Pediatric Clinic at Tufts, they already have this established like lifestyle medicine program that the physicians are going to carry out. And then we're hoping to do shared medical appointments where physicians and registered dietitians meet separately with the parents and the kids. And then they come back together for the end of the session. And then we're adding a food as medicine component. So we're going to see does providing the food that we're recommending people eat in those lifestyle behavioral classes lead to greater behavior change because they don't have to like worry about sourcing the food that we're telling them to eat. So yeah, we haven't done it yet. We're in like we're invited to full proposal stage from a nonprofit. So we're hoping that it gets funded, but either way, we're still doing like a QI version of that program now, and we'll hopefully have results from that soon. But I do think working with the whole family is central because we know that's one of my challenge. If I'm being totally honest with you, that's one of my challenges with like medically tailored meals, because if you're just like providing a prepared meal to one person in the household, like what is everybody else in the home doing? And if that person is like the person who prepares meals, how does that impact like the household dynamics? So I think I have a slight bias or preference for, if I'm just being honest with you, for like medically tailored groceries and produce prescriptions, because I think they're a little more realistic for like how we all live. And how we interact as families. Where I think medically tailored meals are helpful, and this wasn't your question, but now I'm going on. Where I think they're most helpful is for people who like were recently discharged from the hospital, for example, where like you physically can't prepare your meal, so you need that support. Yeah, not your question exactly, but yes, we are thinking about like the whole household for sure.
Yes.
Have you,
Yes, you,
have you seen a study where people have done sort of a graduated move from meals to groceries to produce prescription and study the effects of that sort of intervention based on status, but also with coaching and education?
Yeah, so we would love to. I don't know of one yet. That's actually what we're gonna, this planning grant from AHA with UT Health is to apply for a larger like multi-site trial. And that's what we're actually gonna propose, is like starting with more intensive intervention and then dwindling it down. Cause it goes, that's the most cost effective or most expensive to like more affordable and really integrating into lifestyle behavior change. I do think that my intuition tells me that this kind of stepped approach would be supportive. I guess the constraint is like, does the household have money to buy the groceries inevitably? But with something like food resource coaching, like some of our participants ended up getting jobs as a part of like participating in the food resource coaching, right? So they got assistance around like preparing for a job interview, because it's really guided by the individual, what they want to do for their SMART goal setting. So for some of those people, they would say like, I want to get a job, and the coach would like walk them through those steps. So I think there's these like complementary strategies that can really provide that like whole person care, but none of that has been tested on like a larger scale. I do hope that we move in that direction though, of finding out like how do we titrate these interventions and make them more sustainable long term.
Other questions?
We have one, and of course it's regarding that one GLP slide. But and I know your study was specifically for its secondary use. Did you see a difference in the data with age ranges in muscle loss?
So unfortunately we weren't able to measure that, so I wouldn't be able to say. I think that, yeah, we were talking about this last night at dinner. Yes, can you remind me of your last name? I know your first name.
Oh, Baum.
Baum. Yeah, so Dr. Baum mentioned like a friend who is taking GLP-1s and being really worried about, she is a protein researcher and really worried about the muscle loss and how that might differ by age. So I think probably, I don't know if you could speak to this even more than I
We
can.
all lose muscle as we age, and we lose muscle when we lose weight. And I think you even said the data about what 40% of the tissue loss. So I think it just depends on what they're eating, how much weight they're.
Yeah, I just find it interesting with like the data.
And I know like my friend runs the muscle lab at Eli Lilly. So they're looking at specifically muscle changes across age and the impact of like Monjaro or Zepbound. So I'm sure there'll be like a secondary analysis coming out from Lilly. And they have a new GLP-1 that's coming on the market with the muscle preservation peptide thing.
Rapidly evolving and
Yeah.
On mine?
Yes, if we have time. Yeah. On the FRESH study, this sort of is, it's not exactly the same question that was online, but I was curious if you tracked people's preferences for fresh, frozen, or canned.
Not in that study, but in one of the cross-sectional surveys we did ask, and the highest preference was for fresh. Like people always say they want fresh. The challenge is that people don't always use fresh when it goes to waste.
Yeah.
But there was still really high preference and like acceptance for frozen and canned. Frozen is a little higher than canned. So it was like fresh, most preferable, frozen, canned. And in our study, we did provide a lot of like frozen fruit, for example. One thing I didn't mention too was we did provide the opportunity to select different kitchen tools and appliances as a part of the study. So our most popular was a blender, which I hope would help facilitate like taking those fresh strawberries and making them into a smoothie. But yeah, I think we could also do a better job around communicating the benefit of like canned and frozen produce, which in some instances has a higher micronutrient content than fresh, because they can be flash frozen and preserved at like when they're first picked, whereas the fresh has to travel all over and sometimes loses different micronutrients.
I think because you have to catch a fly. We should keep going on and on and on with this discussion. So I think we are gonna have to close it. But I think we've learned a lot, and I will boldly say that we are very willing to work with you, you know. So I'm gonna challenge our own group of people here to see how we can start to put together a program that we can work with.
Sounds great. I'm very excited. Thank you so much for having me, and thanks for asking so many great questions.